The Initial Management of Chronic Pelvic Pain. Green Top Guideline number 41, May 2012. Background and Introduction. Chronic pelvic pain can be defined as intermittent or constant pain in the lower abdomen or pelvis of a woman of at least 6 months in duration, not occurring exclusively with menstruation or intercourse and not associated with pregnancy. It is a symptom, not a diagnosis. Chronic pelvic pain presents in primary care as frequently as migraine or low back pain and may significantly impact on a woman's ability to function. Living with any chronic pain carries a heavy economic and social burden. Aiming for accurate diagnosis and effective management from the first presentation may help to reduce the disruption of the woman's life and may avoid an endless succession of referrals, investigations, and operations. What are the possible etiological factors in the genesis of chronic pelvic pain? There is frequently more than one component to chronic pelvic pain. Assessment should aim to identify contributory factors rather than assign causality to a single pathology. At the initial assessment, it may not be possible to identify confidently the cause of the pain. Pain is, by definition, a sensory and emotional experience associated with actual or potential tissue damage or described in those terms. The experience of pain will inevitably be affected by physical, psychological, and social factors. The woman is often aware of these influences, but may choose not to discuss them, fearing that her pain will be dismissed as psychological or that non-gynecological symptoms will be considered irrelevant. Careful scrutiny of the woman's history and physical findings will frequently reveal factors that may be contributing to the pain and can therefore be at least partially treated. Given the incomplete understanding of the genesis of pelvic pain, it may be necessary to keep an open mind about the cause and consider unusual diagnoses such as hernias or retroperitoneal tumors. It is important not to leave the woman with the feeling that nothing more can be done to help her. Central and peripheral nervous system. Nerve damage following surgery, trauma, inflammation, fibrosis, or infection may play a part in this process. Pain as a result of changes in the nerve itself is termed neuropathic pain and is characteristically but not exclusively burning, aching, or shooting in nature. Endometriosis and adenomyosis. Pelvic pain, which varies markedly over the menstrual cycle, is likely to be attributable to a hormonally driven condition such as endometriosis. The cardinal symptoms of dysmenorrhea, dyspareunia, and chronic pelvic pain are said to be characteristic of endometriosis or adenomyosis. The combination of clinical examination and transvaginal ultrasound accurately identifies ovarian endometriosis but not peritoneal disease. Symptoms alone are a pure predictor of finding endometriosis at surgery, but a causal association between the disease and the severe dysmenorrhea probably exists. It is important that dysmenorrhea in adolescents is not overlooked, as adenomyosis and endometriosis certainly occurs in the group. The existence of pelvic venous congestion as a cause of chronic pelvic pain remains controversial. A recent systematic review of diagnosis and management of this condition found no valid diagnostic tests, although ovarian suppression was effective in treating pelvic pain symptoms. In women suspected of having this condition, both progestins and gonadotropin-releasing hormone agonists were shown in randomized controlled trials to effectively decrease pain during therapy, with gonadotropin-releasing hormone agonists showing higher efficacy. Strikingly, cyclical pain is likely to be gynecological in nature. Adhesions. There is no evidence to support the division of fine adhesions in women with chronic pelvic pain. Division of dense vascular adhesions should be considered as this is associated with pain relief. Adhesions may be a cause of pain, particularly on organ distension or stretching. Dense vascular adhesions may cause chronic pelvic pain. However, adhesions may be asymptomatic. Adhesions may be caused by endometriosis, previous surgery, or previous infection. Two distinct forms of adhesive disease are recognized. One, residual ovary syndrome, in which a small amount of ovarian tissue inadvertently left behind following oophorectomy, which may become buried in adhesions, and second, trapped ovary syndrome, in which a retained ovary becomes buried in dense adhesions post-hysterectomy. Removal of all ovarian tissue or suppression using a gonadotropin-releasing hormone analog may relieve pain. Irritable bowel syndrome and interstitial cystitis. Symptoms suggestive of irritable bowel syndrome or interstitial cystitis are often present in women with chronic pelvic pain. These conditions may be a primary cause of chronic pelvic pain, a component of chronic pelvic pain, or a secondary effect caused by efferent neurological dysfunction in the presence of chronic pain. Musculoskeletal. Musculoskeletal pain may be a primary source of pelvic pain or an additional component resulting from postural changes. Pain may arise from the joints in the pelvis or from damage to the muscles in the abdominal wall or pelvic floor. Pelvic organ prolapse may also be a source of pain. Spasm of the muscles of the pelvic floor is proposed as a cause of pelvic pain, which can be reduced by botulinum toxin injections. Nerve entrapment. Nerve entrapment in scar tissue, fascia, or a narrow foramen may result in pain and dysfunction in the distribution of that nerve. The incidence of nerve entrapment, defined as highly localized, sharp, stabbing, or arching pain, exacerbated by particular movements, and persisting beyond 5 weeks, or occurring after a pain-free interval, after one Phalansteal incision is 3.7%. Psychological and social issues. Inquiry should be made regarding psychological and social issues which commonly occur in association with chronic pelvic pain. Addressing these issues may be important in resolving symptoms. Depression and sleep disorders are common in women with chronic pain. This may be a consequence rather than a cause of their pain, but specific treatment may improve the woman's ability to function. Similarly, women with chronic pelvic pain tend to suppress their unwanted thoughts and feelings, either as a cause or consequence of their pain. The relationship between chronic pelvic pain and sexual or physical abuse is complex. Those who experience chronic pelvic pain specifically are more likely to report sexual abuse than women with another chronic pain complaint. It may be that, for some individuals, child sexual abuse may initiate a cascade of events or reactions which make an individual more vulnerable to the development of chronic pelvic pain as an adult. Women who continue to be abused are particularly at risk. What should underline the initial assessment of chronic pelvic pain? Adequate time should be allowed for the initial assessment of women with chronic pelvic pain. They need to feel that they have been able to tell their story and that they have been listened to and believed. Many women present because they want an explanation for their pain. Often, they already have a theory or a concern about the origin of the pain. These ideas should ideally be discussed in the initial consultation. Consultations which elicit the patient's ideas will result in a better doctor-patient relationship and improve concordance with investigation and treatment. Women with chronic pelvic pain want the experience to be heard and validated, and they want to receive personal care to help them understand and manage their pain. Particularly if they have had negative experiences previously, women may need to be encouraged to talk about their symptoms and ideas, allowing them to influence and shape the doctor-patient relationship as a partnership. The multifactorial nature of chronic pelvic pain should be discussed and explored from the start. The aim should be to develop a partnership between the clinician and the woman to plan a management program. An integrated approach with equal attention devoted to possible organic, psychological, dietary, and environmental causes of pain causes greater pain relief. History. The initial history should include questions about the pattern of the pain and its association with other problems such as psychological, bladder and bowel symptoms, and the effect of movement and posture on the pain. Symptoms alone may be used to diagnose irritable bowel syndrome positively in this group. On taking the woman's history, special note should be taken on any red flag symptoms, which may need further investigation and referral to a specialist. If the situation allows, it may be helpful to ask directly about past or present sexual assault, particularly intimate partner violence. The doctor must be prepared to listen and accept these experiences as stated and know where to access specialist support. Completing a daily pain diary for 2 to 3 menstrual cycles may help the woman and the doctor identify provoking factors or temporal associations. The information may be useful in understanding the cause of the pain. It may be helpful to establish the woman's level of function at the start of treatment, for example, time of work, avoiding activities, both to monitor progress and to emphasize the value of functional goals. Asking which drugs have been used previously and whether or not they helped may be helpful both to aid diagnosis and to plan effective management. A number of validated symptom-based tools are also available for the detection of psychological comorbidity. However, simply inquiring generally about things at home and symptoms such as sleep or appetite disturbance and tearfulness may be enough. If the history suggests to the woman and doctor that there is a specific non-gynecological component to the pain, referral to the relevant healthcare professional such as gastroenterologist, urologist, genitourinary medicine physician, physiotherapist, psychologist, or psychosexual counselor should be considered, usually via the general practitioner. Examination. The examination is most usefully undertaken when there is time to explore the woman's fears and anxieties. The examiner should be prepared for new information to be revealed at this point. The assessment should include abdominal and pelvic examination, looking particularly for focal tenderness, enlargement, distortion or tethering, or prolapse. Highly localized trigger points may be identified in the abdominal wall and/or pelvic floor. The sacroiliac joints or the symphysis pubis may also be tender, suggestive of a musculoskeletal origin to the pain. What investigations should be undertaken? Screening for infection. Suitable samples to screen for infection, particularly chlamydia, trachomatis, and gonorrhea, should be taken if there is any suspicion of pelvic inflammatory disease or PID. All sexually active women with chronic pelvic pain should be offered screening for sexually transmitted infections or STI. A positive endocervical sample supports but does not prove the diagnosis of pelvic inflammatory disease. The absence of a result positive for chlamydia, trachomatis, or gonococcus does not rule out the diagnosis of pelvic inflammatory disease. If PID is suspected clinically, this condition is best managed in conjunction with genitourinary medicine physician in order that up-to-date microbiological advice and contact tracing can be arranged. Transvaginal scanning or TVS and magnetic resonance imaging or MRI. Transvaginal scanning is an appropriate investigation to identify and assess adnexal masses. Transvaginal scanning and magnetic resonance imaging are useful tests to diagnose adenomyosis. The role of magnetic resonance imaging in diagnosing small deposits of endometriosis is uncertain. A systemic review of the value of transvaginal scanning in the diagnosis of endometriosis found that endometriomas may be accurately distinguished from other adnexal masses. It is also useful in identifying structural abnormalities such as hydrosalpinges or fibroids, which may be relevant even if not the cause of the pain. Transvaginal scanning is of little value for the positive identification of other causes of chronic pelvic pain, including peritoneal endometriosis. The sensitivities of magnetic resonance imaging and transvaginal scanning for the diagnosis of adenomyosis are comparable in the best hands. While magnetic resonance imaging lacks sensitivity in the detection of endometriotic deposits, it may be useful in the assessment of palpable nodules in the pelvis or when symptoms suggest the presence of rectovaginal disease. It may also reveal rare pathology. Diagnostic laparoscopy. Diagnostic laparoscopy has been regarded in the past as the gold standard in the diagnosis of chronic pelvic pain. It may be better seen as a second-line investigation if other therapeutic interventions fail. Diagnostic laparoscopy may have a role in developing the woman's beliefs about her pain. Diagnostic laparoscopy is the only test capable of reliably diagnosing peritoneal endometriosis and adhesions. However, it carries significant risk, an estimated risk of death of approximately 1 in 10,000, and a risk of injury to bowel, bladder, or blood vessel of approximately 2.4 in 1,000, of whom 2/3 will require laparotomy. Clearly, conditions such as irritable bowel syndrome and adenomyosis are not visible at laparoscopy, but there is also a risk that some forms of endometriosis will be missed. Endometriosis is a disease with a large variety of appearances and is considered significantly underdiagnosed at laparoscopy. All suspicious areas should be biopsied. It is well known that the existing scoring systems do not correlate with severity of pain and that deeply infiltrating endometriosis, which is strongly correlated with pain, may be misinterpreted as a minimal disease. 1/3 to 1/2 of diagnostic laparoscopies will be negative, and much of the pathology identified is not necessarily the cause of pain. There may be adverse consequences of a negative laparoscopy. Many women may feel disappointed that no diagnosis has been made. This set of events may lead to disengagement with the medical process. The risks and benefits of diagnostic laparoscopy and the possibility of negative findings should be discussed before the decision is made to perform a laparoscopy. Perhaps it should be performed only when the index of suspicion of adhesive disease or endometriosis requiring surgical intervention is high. CA 125. Women reporting any of the following symptoms persistently or frequently more than 12 times per month: bloating, early satiety, pelvic pain, or urinary urgency or frequency, should have a serum CA 125 measurement taken. Particularly in women over the age of 50 years, any new irritable bowel syndrome symptoms should prompt such action. What therapeutic options are available? Women with cyclical pain should be offered a therapeutic trial using hormonal treatment for a period of 3 to 6 months before having a diagnostic laparoscopy. Women with irritable bowel syndrome should be offered a trial with antispasmodics. Women with irritable bowel syndrome should be encouraged to amend their diet to attempt to control symptoms. Women should be offered appropriate analgesia to control their pain even if no other therapeutic maneuvers are yet to be initiated. If pain is not adequately controlled, consideration should be given to referral to a pain management team or a specialist pelvic pain clinic. Ovarian suppression can be an effective treatment for cyclical pain associated with endometriosis. The effect can be achieved with a combined oral contraceptive, progestogens, danazole, or gonadotropin-releasing hormone analogs, all of which are equally effective but have differing adverse effect profiles. The levonorgestrel-releasing intrauterine system by Mirena or Bayer could also be considered even in adolescents. Non-endometriosis-related cyclical pain also appears to be well controlled by these treatments. An economic evaluation of the use of gonadotropin-releasing hormone analogs as empirical treatment for cyclical pain prior to laparoscopy demonstrated improved patient and physician satisfaction at reduced cost. Smooth muscle relaxants such as mebeverine hydrochloride are beneficial in the treatment of irritable bowel syndrome where abdominal pain is a prominent feature. The most commonly implicated foods were dairy products and grains. Regular non-steroidal anti-inflammatory drugs with or without paracetamol may be particularly useful. Compound analgesics such as codridramol may be appropriate. For the general gynecologist, it is probably unwise to prescribe opioids for regular use in women with chronic pelvic pain. Adjuvant treatments such as amitriptyline or gabapentin may be useful in the treatment of neuropathic pain. Non-pharmacological modalities such as transcutaneous nerve stimulation, acupuncture, and other complementary therapies may be helpful for some women. Dietary modifications may also relieve pain. Laparoscopic uterosacral nerve ablation or LUNA is ineffective in the management of chronic pelvic pain. Voluntary organizations such as Endometriosis UK can be an important source of information and support for some patients. Summary. Chronic pelvic pain is common, affecting perhaps 1 in 6 of the adult female population. Much remains unclear about its etiology, but chronic pelvic pain should be seen as a symptom with a number of contributory factors rather than as a diagnosis in itself. As with all chronic pain, it is important to consider psychological and social factors as well as physical causes of pain. The assessment process should allow enough time for the woman to be able to tell her story. This may be therapeutic in itself. A pain diary may be helpful in tracking symptoms or activities associated with the pain. Where pain is strikingly cyclical and no abnormality is palpable at vaginal examination, a therapeutic trial of ovarian suppression may be more helpful than a diagnostic laparoscopy. Other conditions, such as irritable bowel syndrome, require specific treatment. Even if no explanation for the pain can be found initially, attempts should be made to treat the pain empirically and to develop a management plan in partnership with the woman. Appendix 1. Rome 3 Criteria for the diagnosis of irritable bowel syndrome. Continuous or recurrent abdominal pain or discomfort on at least 3 days a month in the last 3 months, with the onset at least 6 months previously, associated with at least 2 of the following: improvement with defecation, onset associated with a change in frequency of stool, onset associated with a change in the form of stool. Symptoms such as abdominal bloating and the passage of mucus are commonly present and are suggestive of irritable bowel syndrome. Extraintestinal symptoms such as lethargy, backache, urinary frequency, and dyspareuria may also occur in association with irritable bowel syndrome. Appendix 2. Red flag symptoms and signs. Bleeding per rectum. New bowel symptoms over 50 years of age. New pain after the menopause. Pelvic mass. Suicidal ideation. Excessive weight loss. Irregular vaginal bleeding over 40 years of age, and postcoital bleeding.